ಫುಲ್ಲಾಗಿದೆ ಸರ್. something about Why put your eye? Start, Harish.
Good afternoon, one and all, the dignitaries, the family of SDUHR, researchers from other colleges, academies, and the stakeholders. So I feel it a privilege to be hosting this webinar on behalf of Department of Biochemistry. Now I call upon Mr. Suma, Clerk of Research and Innovation, Sri Devaraja Academy of Higher Education and Research, to invoke the Almighty to start the occasion.
गजाननं भूतगणादिसेवितं कपित्तजम्बो फलसारभक्षितम् उमासुतं शोकविनाशकारणम् नमामि विघ्नेश्वर पादपङ्कजम् अजं निर्विकल्पं निराकारमेकं निरानन्दमानन्दमद्वैतपूर्णम् परं निर्गुणं निर्विशेषं निरीहं परब्रह्मरूपं गणेशं भजेमा परब्रह्मरूपं गणेशं भजेमा गुणातीतमानं चिदानन्दरूपं चिदाभासकं सर्वगं ध्यानगम्यम् मुनिध्येयमाकाशरूपं परेशं परब्रह्मरूपं गणेशं भजेमा जगत्कारणं कारणज्ञानरूपं सुरादिं सुखादिं गुणेशं गणेशं जगद्व्यापिनं विश्ववन्द्यं सुरेशं परब्रह्मरूपं गणेशं भजेमा गणेशं भजेमा गणेशं भजेमा. Thank you.
Thank you, Mr. Suma. Now to welcome all to this August gathering, I request Vice Principal of SDUMC and our beloved Professor and Head of the Department of Biochemistry, Dr. Shashidhar KN, to deliver the welcome note. Sir, please.
Thank you, Dr. Harish. Let us start today's program with a positive note. In order to carry positive action, you must develop a positive vision. So with this positive note, I welcome one and all to this webinar titled Current Evidence of Health Hazards of Lead as part of the Department of Biochemistry. This is the webinar series that we are hosting it for our esteemed participants and the participants for this webinar. The purpose of this webinar is to link the Center of Excellence, what we are sanctioned with our department, the Fluorosis Research and Referral Lab. We wish to find association with other heavy metal ions in the fluoride. With the purpose, we have started this webinar series. Our institution distinguished itself as a premier institution for medical education. In addition to the research, patient care, community health services, and various other activities, Since its inception in 1986, the hard work, devotion to the quality dedication of the teachers and staff, vision of the management has led to this notable achievement to reach our institution very great height. First and foremost, I pay on behalf of my institution the obeisance to our late beloved Sri R.L. Jalapa sir, whose dynamic leadership is reflected in the vision and mission of our academy, Sri Devaraja Academy of Higher Education and Research, which is established in Kolar, Karnataka, India. I welcome all the dignitaries, our respected President of our trust, Sri G.H. Nagaraja, Vice President Sri Rajendra J, Secretary Sri Hanumantraju K.J, Honorable Chancellor of our Academy, Sri Rajesh N. Jagdale sir, Honorable Vice Chancellor Dr. Pradeep Kumar sir, Registrar of our Academy, Dr. K.N.V. Prasad sir, our beloved Dean, Faculty of Medicine and Principal Dr. P.N. Sriramulu sir, respected Medical Superintendent Dr. S.R. Sheila ma'am, and my colleagues, researchers and stakeholders to this webinar. Today, we have with us Dr. Rakesh B., Scientist D, Department of Clinical Epidemiology of ICMR National Institute of Occupational Health, Ahmedabad, and in-house speaker Dr. Harish, who is Associate Professor of our department, who is hosting the program today. I am proud to say that Dr. B. Rakesh is a proud alumnus of our institution. He did his undergraduate from our institution, and he has done a PhD from National Institute, NIMHANS, Clinical Neurosciences, postdoctoral fellowship in the University of Hamburg, a joint postdoctoral fellow from Canada. His research interest and thrust areas are occupational mental health, heavy metal and toxin related occupational diseases, and emerging non-communicable diseases among the workers. He has got a lot of memberships and affiliations. To say the notable memberships and the affiliations that he has: Alzheimer's Association, International Society to Advance Alzheimer's Research and Treatment, Alzheimer's and Related Disorders Society of India, Neurological Society of India. He has worked a lot on the Alzheimer's and various other diseases linked with the lead and various other heavy metal ions. He is conferred with fellowships and awards. Gold medal in the year 2009 when he was pursuing undergraduation in our institution in the Department of Forensic Medicine. Best Research Award in 2011 by International Congress of Neuropsychiatric Association. Alzheimer's Association International Award in the year 2012. Consequently, in the year 2014, consequently again in the year 2015, 3 times he was conferred with Alzheimer's Association International Award from International Alzheimer's Association. He has got postdoctoral fellowship from University of Hamburg in the year 2015. Again, postdoctoral fellowship from Canadian Institute of Health Research 2016. To his credit, he has got more than 30 national and international publications in indexed journals of global repute. I welcome you, sir. Regarding Dr. Harish, he is both undergraduate and postgraduate alumnus of our institution, and he belongs to he belongs to 2003 batch, 3 batch alumnus of our institution. He did both undergraduate and postgraduate from our institution, and he is presently working as associate professor. To his credit, he has got more than 15 publications, and he has worked a lot on heavy metal ions and other related linked disorders. His thrust areas are diabetes and atherosclerosis. With this brief introduction of both the renowned speakers, let me say a few things of today's webinar. The lead poisoning is considered to be one of the major health hazards due to the environmental toxins. It accounts to 0.6% of the global disease health burden. Lead is a heavy metallic cation occurring naturally in the Earth's crust. The unscientific usage of the lead has resulted in substantial environmental damage and health issues. It is an cumulative toxicant, increasing in quantity in the body over many years, which affects multiple body systems, which includes neurological, hematological, gastrointestinal, cardiovascular, and renal systems, which our notable speakers and renowned speakers will be highlighting today. Ola district, which is in the southeastern part of the Karnataka with an elevation of 849 meters above the sea level, is known for mining and industries. These, along with the scarcity of water, has contributed to many factors contributing to environmental contribution with lead and evincing cases of anemia and other maladies. This webinar shall deliberate on the health hazards of lead and estimation of the lead. Once again, I welcome all the participants as well as the speakers to today's webinar. I welcome Dr. Rakesh and Dr. Harish and to share their experiences with respect to the heavy metal poisoning, toxicants, and various other things. I welcome both of you, sir, as well as our participants. Thank you. Over to Dr. Harish.
Thank you, sir. Thank you for the welcome speech. Now I request our distinguished luminary, Dr. Rakesh B, to present on the current evidence of health hazards of the lead. Over to you, sir. Dr. Rakesh, your audio is...
Dr. Rakesh, are we audible, Dr. Rakesh? Dr. Rakesh, I think you are muted. Dr. Rakesh, am I audible?
Can you hear me now, sir?
Yeah. Please. Please go ahead.
Yes. Are you able to see my full screen or are you able to see my partial screen, sir?
Now we can see the full screen.
Okay, sir. Thank you. Thank you for the exhaustive introduction, sir. Thank you, sir. It's a wonderful experience to speak back into my Alluminous Institute. I thank the head of the division and as well my graduate colleague, Dr. Harish, Professor Harish, for inviting me. And I thank all the dignitaries and honoraries from SDMC for making me a part of this wonderful speech. Thank you once again. I'll go to my presentation. So here I'm about to speak about health hazards of lead exposure. So let me give you a background about, my overview of presentation is I'll be speaking about something about lead. Why is this being a public health problem? And then I'll be speaking about how the lead enters into body and how the body handles lead and how lead affects the system. As you rightly mentioned, lead is considered a public health concern and it affects numerous systems. So let's see how an overview of how lead affects the individual body, and then let's discuss about the existing evidences hazards of lead at individual systems. I would emphasize on how what are the existing evidences on aberrations of calcium homeostasis as a potential endocrine disruptor, and the existing evidences against affecting the Hb levels, and again certain systems like neuro, nephro, hepatotoxicity, and lastly about its smooth muscle functioning. Coming to background, why is lead? I mean, the first primary question: why are we speaking about lead? Why is being lead used for all practical reasons? In the last 3 to 4 centuries, the lead is invention of lead, or the introduction of lead, has been a boon to the revolution or the industrial revolution because of its physico-chemical desirable properties. One of them is the most common at this point of time is its electrochemical reaction when it comes in contact with acid. This has been the reason why the recent lead-based batteries. This is a particular property. So as we move on towards clean energy batteries, we are moving towards electrical energy, and lead-based batteries is one of the most sought lead. As now we're going to lithium batteries as well, but lead battery is one, and it's because of its electrochemical reaction. That is, it lets out cations when it comes in reacts with an acid, which has been useful in generating charges, electricity. And then its chemical stability when it comes in contact with air, water, soil. This makes it a wonderful property, especially in paint, in plumbing industry, wherein the metals, it is essentially covers the surface and prevents any sort of corrosion. So its stability, its chemical stability when it comes to contact with air, water, soil. So this is one more reason why lead is being sought. And the most important in the spectrum of the electromagnetic radiation, the lead has a capacity to absorb the electromagnetic radiation. So it can attenuate sound waves, it can attenuate high intensity X-ray radiations, as well mechanical vibration. So these properties makes lead particularly useful in radiation industries, as well some even in amphitheaters where one has to work in attenuating sound. So it has been a wonderful application there. And then it's not just these properties, but it has a low melting point. Its ability to cast, it has a very high tensile strength, and because of its low melting and ease of casting, it can be fabricated to any shapes and designs. So these properties of lead makes a highly desirable element or highly desirable metal. But as said in a recent movie, with great powers comes great responsibilities. But here, with such desirable properties comes such undesirable health results. That's how I would phrase this. For such desirable properties, they have been used every possible place. If I would have to make this in simple, it is similar to salt in culinary industry. So in all possible industries, lead has reached, unless we are able to find another element or another heavy metal which can have similar properties, till then we will have to continuously use lead. At some places, lead has been replaced. For instance, lead-free paints, lead-free plumbing, and lead-free fuels are there. But however, there are the utilization of lead is far-fetched. As of now, it's quite difficult for us to entirely replace or entirely remove lead from the industrialized process. These are the common causes why we as public are commonly exposed to such lead, particularly during construction blocks. There are various materials which involve lead, and then the appliances, as I mentioned, for various properties earlier. These have been a desirable element in manufacturing telephones, mobile phones, vacuums, washing machines, so etc. So especially when these e-waste, when these electronical devices have to be recycled. That generates enormous amount of lead. We'll see in subsequent what are the hazards of lead when we speak about the e-waste. And in addition to it, though we have eliminated lead back around in the late 90s or probably in the early 20th, in the 2000 decade, the fuel, we have lead-free fuel, but however, the lead that has accumulated over a period of time because of usage in the fuel is still present in the environment, that has leached below the soil into the water, and we continue to consume them to our food chain. So these are the various reasons how the humans are being exposed to lead. This gives a good background why we are being exposed to lead. Next. There are these are common routes of entry. As I mentioned earlier, through food chain is one way how lead essentially enters into our system. That is by GI absorption. And there are, yes, though airway and dermatological are most commonly in occupational. However, these fumes that are let out, the locality, the community residing adjacent to such places do inhale substantial amount of lead in their air. And dermatological is quite a questionable. However, in the past, certain cosmetic and Ayurveda products have been demonstrated to have certain levels of lead, and by such evidences, the presence of lead in the subcutaneous tissues has been demonstrated. So it's most likely because of the dermal application rather than a systemic application that has thrown the lead out. We'll subsequently see how lead enters into systemic and can also be excreted through dermatological tissue. So on a broader sense, the lead absorption is not uniform because lead is being used in multiple chemical broadly in its organic and inorganic form. GI absorption conventionally happens in organic, while airway, as a rule of thumb, but not necessarily, airway, usually the inorganic form is present in the airways, in the air. The organic is usually found in the food substances, or of course not in water. It's definitely organic is definitely water insoluble. GI has a better absorption for organic because of its surface epithelia, and while the organic, the inorganic lead particles are absorbed preferably higher in airways. While dermatology, there's very less evidence for absorption in the inorganic form. And we'll see over a period of time what are the other variables that affect the lead absorption. Of course, one of the factor is the route of entry, and of course, and the other one is the age, especially the younger population. When I mean younger, these are infants less than 5, as compared to adults, have a better absorption. So these are the factors which affects the absorption of lead. Once lead gets into the body, the preference to lead is it gets into circulation, identifies certain soft tissues, and then prominently in autopsies, lead has been found to RQ. 90% of lead is taken over by bones, and maybe a very small proportion, less than 5%, by liver, kidney, less than 1% by other tissues such as skin, brain, skeletal muscle. In fact, there are evidences to demonstrate presence of lead in vascular tissue such as aorta and rarely in heart. But these are all based on few case reports or case series. However, presence of bones, liver, kidney has been documented. Definitely, lead is found in larger quantity in these tissues. So we did understand on a very broader sense how lead gets into. The same has been replicated or discussed in the American regulatory authorities, a model how the lead is absorbed, taken up, and then an attempt by the body to excrete them. So as I mentioned earlier, the sources of lead absorption or exposure is, of course, there are various models, while the integrated exposure uptake biokinetic model is the earliest to develop. It has been updated. There have been individual scientists who have updated or come up with better models. However, as of now, the regulatory bodies consider this model for determining or estimating the probable levels of exposure, and probably to understand to what extent of lead would be available in the body and what proportion of lead would be excreted in the excretory system. So we look into it. As I mentioned, the common sources of exposure are air, of course, diet, again, water. When I say air, again, a part of it can also be inhaled, sometimes through mucociliary response. The lead deposited over the respiratory system refluxes back, comes into esophagus, and it can be solved. So that is one way how air-based inorganic lead can be consumed or can be swallowed up. Apart from this, through soil, and there are other modalities just to not ensure that we close the boundaries. And then, so this is the exposure component. So major route in this kind of model is respiratory tract and GI tract. However, when it comes to the dermatological exposure, it is mostly, as I mentioned earlier, it is either through cosmetological, certain cosmetology has in the past, because of its desirable properties, were used in certain cosmetics to prevent fissures of skin, or so in those kind of exposures, there was a possible route of entry through dermatology. However, after the regulatory bodies banning the usage of lead in all possible medicinal, non-medicinal, and cosmetic products, the absorption of lead through skin is now questionable. So this is the component of exposure, and then how the body handles lead. Once these lead enters into respiratory tract and GIT, they move into extracellular fluid. This is through the respiratory membrane and the GI membrane. There are various calcium, I mean divalent cation channels, or certain ligand-gated channels, or through free perfusion of the membrane, the lead moves across the barrier and it enters into extracellular fluid. While some of them which are not absorbed are excreted as feces. And now, how does the body handle, or how body tries to eliminate the lead? Once the lead is present in the systemic circulation, as I mentioned earlier, they find, or they are deposited in bones. Essentially, they replace calcium, and then which leads to a situation of osteoporosis. And a large chunk of absorbed lead is now reserved in bones. Following, so there is a continuous balance between the systemic circulation and the various tissues, RBCs, kidney, liver, and other tissues. So as in when there is, it follows a conventional T-half procedure, as we looked into earlier pharmacological models, wherein there is a constant balance between the systemic circulation as well the tissues. So when there is reduced exposure, the levels in the systemic circulation reduces, and when they reduce, the lead deposited in these tissues, such as the bone, kidney, and liver, they are released into into the systemic circulation, and they are excreted through urine, and some of them enters into liver, and through enterohepatic circulation, they are removed through feces. So this is the broader understanding of the model. So these are all speculator certain mathematical models derived out of this, which has proven mathematically. Of course, it's quite difficult for one to prove it in a practical mode. Now, trying to understand, we've seen how lead enters and how body handles. So why should we be worried about lead? The most important fact about lead is there is no known physiological role in humans. If we consider other similar to other heavy metals such as arsenic, arsenic and cadmium are the other heavy metals which have no physiological role. However, their lethality is much more severe as compared to lead. And then if we look into other heavy metals such as copper, magnesium, or manganese, there seems to be a certain role of these elements in the human function. Unlike such elements, lead has no known physiological role in humans. So, in reality, or in practical, or in theoretical, or in an ideal condition, the levels of blood in humans should be absolutely zero, or one should not be able to find lead. However, as I mentioned in my earlier slides, because of its vast usage, random usage, and its before we realizing its hazardous nature, for all these reasons, we humans inadvertently have been exposed to lead and have been absorbed lead in some form or the other. Therefore, we would have some levels of lead. As of now, the WHO, or this is based on certain community-based studies, where up to 5 micrograms of deciliter of lead is not considered safe, but however, one need not take any action at public health level. But if one finds a level higher than this, then there has to be an action. The action involves identifying potential sources where an individual is being exposed, and then trying to find to prevent such leakage of lead. That's the public health action with respect to community. So how does lead affect the human body? One proposed understanding is it competitively interacts with divalent ion channels, most commonly calcium, some with zinc, and there are very few or speculated evidence on iron. Of course, there could be other interaction. However, these are based on uh, strong to moderate evidences. It's possible that lead exposure can cause plenty of systemic side effects or systemic effects. However, I believe today we are having a research discussion. So I'd be presenting about the existing evidences from observational studies. And as I said, observational studies are biased, are usually influenced by multiple confounding and covariate factors. So therefore, the evidences can be regarded to an extent of moderate, and that can never be the strongest evidences. And these evidences come from mostly occupationally exposed individuals, because our body is able to better handle lead. I mean, once you have the body, once we are exposed to lead, and if we continue to stop exposing to lead, our body can efficiently excrete them at a very slow process. As I said earlier, the excretion takes in the phenomenon of T-half. So T-half, when any excretion follows the process of T-half, it's relatively infinite amount of time when it reaches zero. So there can be absolutely never a situation when the zero levels can be achieved. So the existing evidences I'd be discussing today are basically from occupational exposed individuals. So before I go into occupational exposure, I believe the participants here would have less understanding about industrial exposure. I'll give a very faint introduction about occupational exposures. So there are regulatory agencies both in India as well as in abroad. In India, it is taken care by a law called as Factory Medical, the Indian Factory Act. And this is regulated by an agency in Mumbai. It's called DG Fastly. It is regulated by labor organization, Ministry of Labor from the center. So according to this, the workplace should be a very safe place, and the companies or the organizations who employ should ensure that the workers are safe. So there are a number of ways how the workplace are controls, administrative controls, and personal protective equipments. So essentially, these workers apparently have to be in a safe situation. I mean, it's just because they are working doesn't mean that they're exposed to high level. Yes, they're exposed, but however, all such exposure had to be controlled, and despite such control, these participants are exposed to relatively higher levels as compared to a community citizens. That's what I would want to give a background. And the next few slides, you would find such graphs. So this is essentially a forest plot. For some of you who may not be familiar with this kind of representation, I'll give you a very small description of how we look into it. So conventionally, on the left side that you see is the list of studies, and then we have two groups, one of them exposed and the other one is the control groups. And then the main differences, the sample size in each of these studies, and then the mean standard deviation among these two groups. And then there exists the mean differences with 95% confidence, and the weightage is drawn based upon the sample size, the mean, and the and the 95% confidence intervals. And this is the graphical representation of what you see on the extreme right. So each of these studies have are represented by a box and whisker plot, wherein the box represents the weightage of this study, while the whisker represents the represents both the weightage as well as the mean difference, while the whisker represents the 95% confidence interval. We have a horizontal x-axis where the 0 represents a line of no difference, while factors on the extreme left are negative, while on the extreme right are positive. So essentially, these are the main differences. So if I subtract lead as compared to control, what is the difference? That's what we're looking at here. So in the earlier slides, I did mention how lead interacts or how lead causes. One of the intriguing factor for me in lead interaction is its role in calcium, which is underplayed in clinical conditions, because even in our experience, we rarely come across hypocalcemia. However, there is the evidences of interaction with lead and calcium can be equivalent to a strong association. It has a very strong association that an individual exposed to lead will affect the calcium levels. But what is the level at which lead exposure causes calcium? It's still a $1 million question. We believe at levels maybe 20-25 milligram per deciliter of microgram per deciliter of lead exposure in the blood can lead to some variations in the systemic calcium levels. Even in our experience, as well as in these studies, we are unable to find those with exposed the calcium levels suggestive of hypocalcemia. They all certainly have lower calcium as compared to those unexposed. However, they do not experience hypocalcemia. So that is one. Whatever evidence we have are towards aberrations, but not towards pathologically disease conditions. So we see there is a definite and a significant reduction in calcium levels as compared to those not among exposed. And which is also seen among in the serum ionized calcium levels. So certainly individuals with lead exposure are at risk of having reduced calcium levels, but I would not go to an extent, or I would be cautious to mention whether they would develop hypocalcemia. I believe the body has efficient systems to regulate the calcium levels such that the calcium stores from the various repositories are brought back to the systemic circulation. Therefore, the individuals are less likely to develop hypocalcemia. And then we went on to investigate whether the hormone, which plays a very crucial role in regulating the calcium levels. Yes, consistent with that, individuals who experience hypocalcemia, they do experience or they exhibit an elevation of parathyroid. It makes sense that and a body's mechanism to improve the calcium levels, they will have to raise the parathyroid levels. So that's exactly what was found in this study as well. And however, it is only a trend and it is not significant. And again, here I would not go to an extent of claiming that individuals exposed to lead would experience hyperparathyroidism. Of course, they develop higher parathyroid levels. It doesn't mean that they would have pathological conditions. And next, the other important factor, vitamin D, which plays a crucial role in calcium homeostasis. The studies definitely document that there is evidences where lead causes hypovitaminosis. I wouldn't say hypovitaminosis, I would go to say reduced vitamin D levels. And there are theoretical or preclinical models where lead is known to inhibit 25 alpha hydroxylase, which is a key hormone present in renal tissues for activation, either cholecalciferol or ergocalciferol to the respective 25 active. So it makes sense that presence of lead obviously causes reduction in the active form of vitamin D, and then therefore which leads to reduced calcium levels. And when there are reduced calcium levels, there is a automatic response for the parathyroid hormones to be elevated such that they can work on other reserve tissues to mobilize the reserve calcium levels and bring them to systemic circulation. So this makes sense or more like a story. However, there needs to be further evidences. These are based on individual pieces of evidences, but we need more data on this to confirm this hypothesis or this cycle. Now, we've seen a particular hormone, vitamin D, and parathyroid, which are affected. So these are hormones. So which gives another question whether lead has any influence as an endocrine disruptor, whether it affects some hormones, not necessarily all, but some hormones, by which we can call, it can be right to call them as endocrine disruptor. On reviewing the literature, we were able to find that lead causes an elevation of prolactin levels. So the exposure, we have no idea how the mechanism works or what is the mechanism, but certainly individuals who were occupationally exposed exhibit high levels of prolactin. From there on, we went on to see whether prolactin affects the reproductive health or reproductive function. In women, it's quite challenging to evaluate the role of lead because of their cyclical hormones, especially among the reproductively active age group. So there has been inconsistent reports. However, the exposure to lead is associated with a unfavorable outcome of pregnancy. So it is statistically associated. However, a definite causal association is quite challenging. I mean, it's quite difficult for us to establish a causal association. But however, in our recent past, we were able to observe relatively higher unfavorable pregnant outcomes. When I mean outcomes such as intrauterine growth retardation or premature delivery. So such outcomes we've observed in pregnant women who had lead levels higher than 5 as compared to women who had less than 5 microgram per deciliter of blood lead levels. And when it comes to men and the FSH, LH, there was a trend of aberrations. However, they were non-significant. On a broader sense, yes, the individuals who were occupationally exposed to lead who had higher lead levels did exhibit significantly lower sperm count as compared to unexposed. So individuals, so I would not go with a simple statement that lead causes a reduced sperm count or infertility. Probably the occupational exposure the occupations aren't certainly involving one single hazard. They may involve multiple hazards, which include relatively longer standing period or high temperature or whatnot. There could be various other hazards as well. But however, industries where lead is being used, individuals employed in such places certainly have a disadvantage in terms of having higher prevalence of infertility. So this is with respect to, so it is still questionable whether lead can be regarded as an endocrine disruptor, but yes, there are some evidences for it to be known as a disruptor. Now, we did look into whether exposure to lead affects the immunological system. We did have some evidences suggesting that exposure to lead causes reduced total count. It's definitely significant. We did look into other immunological parameters, including the lymphocyte count, CD3, helper, and CD8 cells, and other immunoglobulins and cytokines. Our inferences are immunologically, there is a very less of evidences. However, our study did suggest that in continuation to reduce total count, CD4 counts are as well reduced among lead-exposed individuals. In addition to these cell counts, there is also a reduction in interleukin 6. These suggest the role that lead cannot be taken for granted for its known toxicity that has been conventionally reported in our medical books, such as its neurotoxicity or HB. I'll come into the evidences on these as well, but however, we feel that these evidences are being underlooked, and in these things has to be taken care, but not at hospital level, but at public health level. This makes a lot important. So that is with respect to its evidences in immunotoxicity. I mean, as I understand from my first year of my graduation, we've been always discussing about how heme is synthesized, and it is always described that lead inhibits the heme synthesis by its interaction with the alpha amylolevulinic acid deaminase enzyme by competitively binding with zinc. Yes, this is very well theoretically discussed and described, and there are other by its feedback mechanism. Again, it prevents the heme synthesis, and there is again there are these 2 or 3 mechanisms are reported for reasons of reduced heme synthesis. But in reality, in practical situation, what is that we see? We did have a study among e-waste handlers who had very high levels of lead as compared to another control population who had low levels of lead. We also have another set of studies because of certain confidential issues. I'm not reporting it, however, or the results were from lead smelting plant and lead battery workers. So as compared to the individuals who were occupationally exposed, the control population enjoyed the advantage of having higher HB status. There was no doubt exposure to lead is associated with reduced heme. However, the question is, it's whether an individual exposed to lead, do they develop anemia? I mean, when we all speak about HB, we eventually what we look in is development of anemia. Though, but because there are evidences from earlier studies that anemia is pathological, but any amount of HB over and above to a particular extent provides no major advantage. For instance, someone who has HB of more than 16 doesn't, or 14 or 15 doesn't enjoy as compared to somebody who has 13. So this, based on this, yes, there is a risk of reduced hemoglobin. However, I believe the body has mechanisms where it can adapt and raise the hemoglobin over and above to an extent where the individual does not suffer from anemia. So the prevalence of anemia in these populations were in fact similar or same as the community anemia prevalence. Reviewed certain past literature from countries like Iran, from China. The situation is the same, that the prevalence of any anemia is not higher among them. However, they do experience reduced hemoglobin. Well, it's quite questionable. The reason behind one who are engaged in occupational health would understand a concept called as healthy workers problem, wherein an individual who is healthy is likely to continue, while an individual who has developed a disease or has developed some sort of disadvantage either is removed by screening process by the industry, or the individual himself comes out of the industry. So for those reasons, those population who are being investigated by during such occupational health, there's always a bias of healthy workers effect. So I am unable to conclusively say whether the body can replenish anemia or replenish back to get into a status of non-anemia. I'm unable to give you, but however, definitely lead exposure is a risk for reduced hemoglobin. So this is the inference from regarding hemoglobin. Now, with its small menial functions, whether the lead affects smooth muscles, theoretically yes, because calcium is a second messenger, and lead definitely is associated with aberration in serum calcium levels. And by these reasons, yes, theoretically it is possible for lead to affect the smooth muscle functioning. So lead is definitely associated with higher prevalence of hypertension. There are various speculated or hypothesized mechanisms how lead-induced hypertension develops. One of the mechanism is by its attenuation of or by its mechanism affecting the sympathetic and parasympathetic system, as well by its direct action at smooth muscle contraction and relaxation. In our experience as well, the prevalence of blood pressure among these exposed individuals were perhaps similar, the prevalence of prehypertension as well as hypertension, but similar in the community samples. So here, our observation does not indicate that they definitely develop hypertension, but they are at risk of having relatively higher blood pressure. Whether it leads to a hypertension situation, a pathological condition, still is debatable. And as I mentioned earlier, we are unable to solve the healthy workers effect to conclusively say our inferences. In our observation, we have been consistently seeing that individuals have relatively higher increase in diastolic blood pressure as compared to systolic, and that's our observation. Now, with its effect on intestinal smooth muscles, a particular recent study from Iran have observed that individuals who come to a clinic for colic pain had higher lead levels. However, these individuals also were exposed to opiates. The study definitely provides some evidences that lead exposure on chronic low levels can cause a colic pain. Please be mentioned, I'm not speaking about acute exposure, or we're not addressing health forum, we're addressing research forum here. I'm sure in our graduate days or during there is a whole lot of literature which suggests exposed to high levels of lead is associated with colic pain, no doubt about it. But what my references are with respect to public health concern at levels where an individual is exposed to very low levels, and at such low levels, the chances of colic pain or intestinal smooth muscle contraction is relatively rare. I have not included here the other potential smooth muscle contraction would be respiratory muscles, but that is again related to hyperactive airway diseases, where an individual with a susceptibility of hyperactive airway is likely to develop a contraction rather than generally having a asthma or a hyperactive airway condition. Now, with respect to neurotoxicity, yes, there are case reports and case series reporting in the biopsy of an Alzheimer's or a Parkinson's presence of higher levels of lead, but these are individual cases, doesn't necessarily give a causal association, because an individual is certainly exposed to lead during their entire lifetime. There is a possibility that the lead may deposit in certain tissues, but there is no clear indication whether it leads to a degenerative condition. I was a part of an earlier study which involved stem cells, or I would say cell culture. So when these cell culture, which had properties of neural cell, when they were exposed to high levels of lead in the laboratory condition, of course, to be honest, such levels of lead would never be possible in real situations. So when these cells, which had neural properties, were exposed to high levels of lead, they did have higher expression of proteins which had similar properties of amyloid protein. So thereby, it can be a possible theory that lead exposure at very high levels can induce a pathological protein similar to Alzheimer's pathology protein, which is amyloid beta. This is some evidence with effect with relevant to neurodegeneration. Of course, in the occupationally exposed individuals, they have exhibited certain cognitive deficits which are related to reduced attention, reduced speed of processing, reduced visual or verbal memory. And again, when I mention here hearing and vision, it's not about they're hard of hearing or they develop a vision impairment. It's essentially the cognitive process wherein the information delayed or processed through these sensory modalities are affected. So there are a good amount of observational studies, but we need more evidences to document the causal association between these things. Coming to schizophrenia, there has been a large debate. There is a huge theory behind that schizophrenia is a presenile degenerative condition, while there is another theory that schizophrenia is a developmental disorder. However, in either of these conditions, in autopsies, there presence of higher lead levels in few case reports. So based on this, there is a speculation whether in acute toxicity, lead is associated with delirium and certain psychotic behavior. So these are all speculations why schizophrenia may have a risk because of lead exposure. And now, it's very common during in the clinical practice. It has been mentioned the causes for foot drop or such peripheral neuropathy. Yes, lead exposure is associated with demyelinated peripheral neuropathy, but these are again very rare, and only case reports are reported, and we are less likely to find in our regular occupational health research setup. Lastly, yes, there are a good number of evidences to document the infants whose mother or maternal exposure of lead levels. Yes, these individuals or these infants have a risk of developing certain developmental disorders such as autism, hyperactivity conditions, but these are based on some certain observational studies alone. Few case reports as well from community-based studies. They have documented an increased prevalence of kidney disease among individuals with relatively higher levels of lead and elevated renal function parameters such as serum creatinine, blood urea, or GFR among occupational group. Again, here the individuals do not land up having a renal dysfunction. However, they probably have an insult, and the body is able to take care of it. And most important is one should not permit these individuals to be continuously exposed. Once they are being exposed, one should take adequate care that further exposure is prevented, which will certainly help the individual to recover from whatever the renal or the hepatic insult. Hepatic insults leading to AST or ALT elevation. But however, an absolute condition like hepatic cirrhosis or hepatitis, there has been very less or no reports suggesting of lead associated with such conditions. Again, I would have to have this disclaimer saying that these studies are limited or strongly biased by a factor called as healthy workers condition, because once an individual who is employed or who develops an illness is likely to be removed out of the work either because of the organizational mandate or the individual perceives that it is not worthy for him to work in such a condition and earn money. So the individual generally leaves the workplace. That's one big bias, and we are unable to follow such participants. On a broader scope, I would like to summarize the findings or the discuss the earlier points that lead exposure has a very strong association by its interaction with divalent cations, particularly calcium. There is good amount of evidences to suggest that yes, lead exposure causes cations. But now, does an aberration in the calcium ion and its influence as secondary messengers, either at neural or muscle tissue, brings its effect, or because of the lead and cation protein interaction, does it lead to an abnormal protein? So these are huge amount of questions that needs answering, that needs to be answered. Current evidences suggest there are moderate to strong association with lead being associated with elevated blood pressure, affecting hemoglobin synthesis, and to some extent neurotoxicity. There exists a huge gap in understanding whether there, of course, with respect to biomedical research, one has to understand generalizability. With the risk of generalizability, there is a concept of individual susceptibility. So just because someone is exposed gets an illness doesn't mean that everyone exposed gets an illness, because of this factor called as individual susceptibility. So this has to be explored. What are those individual susceptibility which provides preventive or a factor that protects from such aberrations or deteriorations? And then, as I mentioned, we need to understand what are the proteins where the lead interacts, causes aberrations or abnormalities. And one has to, it is still unclear what are the levels of lead at which an individual experiences or would be considered as unsafe or hemoglobin or elevated renal function parameters or elevated liver function parameters. But what levels of lead would an individual develop these elevation as a pathological condition is yet to be assessed. Currently, there is no safe, no recommended, but there is some term called as tolerable or permissible levels, which is unconventional or unconventional in nutritional words or in pharmacological terms. Here, the WHO gives this term permissible level is because anything less than, it doesn't mean that presence of 5 micrograms is safe. It just means that anything over and 5 should have a serious action. Similarly, at occupational levels, there are agencies which recommend 40 as a level at which the individual has to be immediately taken an action in terms of preventing from further exposure or ensure the workplace is a better condition. So 40 is a magical number. However, certain agencies are more conservative in their action. So they have 30 as their action, but this does not ensure that someone who has 30 will develop an illness, or someone who achieves 40 will develop an illness. At times, an individual with less than 20 or 25, because of their high susceptibility, may develop such pathological conditions. So this research gap has to be addressed. Finally, I acknowledge all the authors who have permitted me to utilize their images, and some of the animations or clip arts are taken from Google Images. And thank you, and I'm happy to take questions.
Thank you, Dr. Rakesh, for the insightful session on the exposure to lead and the various evidences available. The session is now open for discussion. Any questions the participants can ask or even post in the chat box? While we wait for the participant questions, in the meantime, I'll just load the next presentation. Okay, any questions can be posted in chat box. We'll revert back to it. And now I'd like to thank Dr. Rakesh for the wonderful presentation. And now we'll be moving on to the next presentation on the analytical considerations of lead estimation, which will be presented by myself, Dr. Harish R, Associate Professor of Department of Biochemistry. At the outset, I would like to thank Professor and Head Dr. Shashidhar KN, Department of Biochemistry, for providing me with this opportunity to be presenting on the analytical considerations of lead estimation. My presentation is outlined as introduction, measurement of lead in the blood, analytical methods of blood lead estimation, laboratory practices, and concluding summary. This presentation, it shall provide a brief overview of the commonly used analytical methods for estimating the lead concentration, and it is primarily intended to inform the healthcare professionals as well as the academia and policymakers who are not laboratory specialists and may need some idea to develop the plans for the human biomonitoring and for conducting various studies of exposure, screening. Now, as we heard from Dr. Rakesh's presentation about the biokinetics and biodynamics of lead, so now we have an understanding that this lead is all pervasive, wherein it can affect any of the organ systems, which includes neurological, hematological, gastrointestinal tract, cardiovascular, musculoskeletal, and the renal systems. And it may be associated with one other diseases as well. And now coming to the identification of the lead poisoning, wherein the signs and symptoms may be overlapping with the other target organ system diseases as mentioned earlier on. So there is a onus upon measurement of the lead exposure, and especially in the children, as Dr. Rakesh clearly mentioned, that 5 microgram per deciliter, there is need not be a cutoff. It can be again a individual susceptibility, the gap for which has to be built, right? So this again, why I mentioned about the children or the pediatric age group is because the lead exposure is known to impede the cognitive development in the children, even at even the lower levels of exposure also. Now, what are the instances wherein this blood lead estimation should be done? Or the question is, why measure blood lead concentration? One is to identify and remove the source of exposure, wherein if it is occupational, as Dr. Rakesh was mentioning, there is a lot of occupational exposure to lead which is happening. Second, it could be for the health screening and surveillance purpose, wherein we might have to check for the environmental exposure to the lead. As we got to know from the previous presentation that the lead can be all pervasive. 3, to determine the effectiveness of the risk mitigation measures. So the policy makers, the recommendations which are made and the measures taken up to see the effectiveness of these. So the risk mitigation purpose will have to measure the blood lead concentration. 4, for the occupational exposure monitoring. So for the human biomonitoring, we'll have to measure the blood lead concentration. So when we tell measurement or quantification, so there will be a unit of measurement to express the same. So for lead, it is micrograms of lead per deciliter of blood, or it can be expressed as micrograms of lead per liter, or it can also be expressed as micromoles of lead per liter. So here for the conversion from mass to molar units, we use the atomic mass of lead, that is 207.16, which is used. So if we are converting it from mass to molar units, it should be divided by 207.16. If we are converting it from molar to mass units, we are going to multiply it by 207.16. However, we should also keep in mind the deciliter to liter conversion also. Now, the lead exposure can be checked using the various biological materials which are available, which includes the blood, serum, urine, even the cerebrospinal fluid for understanding the neurotoxicity, and also the hair can be used for checking the exposure to not only lead, even the other heavy metals also. Now, regarding the type of sample or the specimen, I'll be mentioning in the subsequent slides. So here, when we talk about the biological materials or the samples, so even when we are collecting the blood, so we should keep in mind the various components of the sample collection, storage, transport, and manipulation or handling of the sample or the specimen, because there is every risk of contamination which is possible, especially when we discuss about the lead, as it can be present even in the skin also. When it comes to blood specimen, it can be two things. One is the venous blood, other is the capillary blood, both of which are collected using the universal standard precautions. So when we comment on the capillary blood, so here capillary blood is mainly for which you can call it as non-invasive. It is mainly used for the screening purpose, wherein there are instruments which are based on the anodic stripping voltammetry technique, which can detect the presence of lead with a sample size as less as 50 microliters. We'll come to the analytical considerations of these in subsequent slides. Whereas venous blood is for mainly when we are making the decisions, the clinical decisions of managing a case of lead poisoning. So preferably it will be the venous blood and estimation done by various laboratory methods. Now, regarding the exposure, the usual specimens, one I mentioned earlier on itself, that is the venous blood or the capillary blood. Capillary blood, again, it is on the spot or in the field visits. Whereas when we are collecting the venous blood, so caution should be kept in mind, wherein the vacutainer with which we are collecting is specifically, it will be the vacutainer, that is the royal blue top vacutainer, which is containing the EDTA, wherein this is a metal-free vacutainer. So this is a metal-free vacutainer with the royal blue top, which should be used. And when we are collecting the sample, that is the urine sample, it shall be in a sterile, acid-washed, metal-free container. Okay. So these are the two commonly collected specimens for the estimation of lead. Regarding the analytical methods for measuring the blood lead, so there are various laboratory methods which are available, as well as there are point of care testing devices also. When it comes to the laboratory testing, it requires the skilled technicians who are trained. Whereas the drawback for point of care testing is that when we are collecting the sample for the POCT, therein we should also keep in mind about the environmental factors, something as simple as cleaning the site of collection of the capillary blood, like the heel prick in infants or newborn, or when it comes to the finger prick also, we should wipe the site cleanly. Now to discuss in brief about the various laboratory methods and the point of care testing. The headings which will be taken into consideration will be the methods, their strengths and limitations. And among them, I will be discussing about the common reference methods which are used. So we have commonly used reference methods for laboratory testing. There is the atomic absorption spectrometry, wherein the modifications of this, that is the flame atomic absorption spectrometry and electrothermal atomic absorption spectrometry is used. With the advent of technology, the flame atomic absorption spectrometry is less commonly used, and the electrothermal atomic absorption spectrometry is preferred over it. And here the change being the use of the graphite tube, wherein the blood sample is atomized and the lead which gets once it is atomized, the lead element, it gets excited, and also it will start absorbing the light. So the amount of light which is being absorbed is directly proportional to the concentration of the lead in the sample. And this atomic absorption, now for increasing the limit of detection, this there has been further advent in technology, wherein the inductively coupled plasma mass spectrometry is now commonly used to detect even the lower levels of exposure also, wherein the plasma is inductively, which is exposed to the induction heating, and it is utilized in a process similar to that of the atomic absorption spectrometry, and the lead is quantified. flame atomic absorption spectrometry, I already mentioned. So next is the anodic stripping voltammetry, wherein the three electrodes are used, one being the reference electrode, another is the mercury electrode, and one more electrode to create the potential, wherein what is done initially is the blood sample is treated, and it may to make sure that the lead is released. For example, if you're looking at the anemia induced because of exposure to lead, so our focus is on the lead which is present inside the RBCs. So the RBCs are treated in so that the lead is released, and this there is the mercury electrode, the potential is increased, wherein it will start attracting the lead, or it is decreased to such an extent wherein the lead gets coated on to the mercury electrode, and later on the potential is increased so that there will be a stripping of the lead from the mercury electrode, wherein this will create a electrical potential, and this electrical potential is recorded. So this anodic stripping voltammetry has been further modified into portable devices, wherein it is used for the field studies. Now, to comment on the strengths and limitations of the various methods, the first one is the flame atomic absorption spectrometry. The strengths are it has a short analysis time of seconds, relatively easy to use with a fewer interferences or interfering substances, relatively low capital and running costs compared to ICP-MS. Limitations, it requires a large sample volume, and there is a detection limit of 5 microgram per deciliter. And since we are using the flammable gases here, like the acetylene, so caution should be kept because of the accidents which can occur. Regarding the electrothermal atomic absorption spectrometry, the strengths are it has a lower limit of detection of less than 1 microgram per deciliter. It can analyze smaller sample volumes of 50 to 100 microliters, can be fitted with the auto sampler so that multiple samples can be processed, increasing the throughput of the instrument, and it has well documented applications, and it can be left unattended, and there is no need for the sample preparation. Limitations of the electrothermal atomic absorption spectrometry is it requires the skilled professionals. So laboratory expertise is required, and longer analysis time decreases the sample throughput. Now, to comment on the inductively coupled plasma mass spectrometry, which is now commonly used for the confirmatory diagnosis. Here, strength is that a very low limit of detection of 0.02 micrograms per deciliter also can be identified, and it can analyze small sample volumes of 50 to 100 microliters, and the analysis time is less than a minute. It has a wide analytical working range, and it also, with this, we can detect other heavy metals as well. So this can be used for multi-element capabilities for larger sample runs. Then it has a potential to perform even the isotopic ratio analysis also, wherein with which you can identify the source of this lead exposure. However, limitations of this ICP-MS are the high running costs and purchase. Second, again, this also requires the highly skilled laboratory personnel, and analysis of large number of samples here, rather than putting it as a limitation, what I would like to comment here is benefit over that of the ETAS is that the cost is relatively cheaper if the volume of samples numbers is if it is increased. Next, for the field testing, we have the point of care testing devices which are based on the anodic symmetric volumetry, wherein the strengths include the small sample size of 50 microliters, that is the capillary blood, can be used. It can be used at non-laboratory sites, and I mentioned about the finger prick earlier on. So it is simple to use, does not require skilled laboratory personnel, low purchase and running costs. It gives rapid results of less than in 3 minutes. We can comment on the results. And it has a comparable accuracy with the laboratory based methods. So what was done here was with regard to the portable ASVs, so split sample protocol was followed to establish the accuracy of these ASVs, or places where the access to the ICP-MS is not there. So there we can perform a split sample protocol or analysis wherein the same samples which are run in the portable ASV instrument can be run again with the inductively coupled plasma mass spectrometry and compare the results. So there have been studies wherein the ASV was known to give accurate results. To comment on the limitations, it has a limited analytical working range wherein the levels above 5 microgram per deciliter, if it is identified, we have to again go for confirmatory investigations or confirmatory tests with the laboratory techniques. There is a high risk of sample contamination here. Then risk of low bias results when compared to the venous blood. Again, this was documented also with the use of the portable instrument, wherein there was a recall of certain analyzers by the FDA also. But again, now because of the falsely low lead levels which are detected. So this has to be, caution should be kept in the mind. But again, as I mentioned, the benefit is that of using it for non-laboratory sites like in the field visits for screening purpose. Now coming to the choosing the appropriate instrumentation, we again have to look into the reason for analysis, whether we want to test it in the field for screening purpose or whether it is going to help in the clinical decision making has to be kept in the mind. And also another thing is the number of samples to be tested, if there is any cost limitations which is there. And last but not the least is the availability of trained personnel and equipment for the performing the analysis. Now, for the laboratory methods, when you're opting for the laboratory methods, another thing which should be kept in the mind is choosing a laboratory. So, what are the factors which we have to keep in the mind while we have to choose a laboratory for the lead analysis? So, these are the things. One is it should be accredited for the lead analysis. We should also pay attention to the instrumentation, then the capacity to handle sample, cost, and also
Today, you got scared.
so the accredited laboratories can be searched using the
Today,
ILAC portal.
Amisha is coming with you in bus because we are taking her gadi. We are going to Lighthouse.
So now regarding the point of care testing devices, so as I mentioned earlier on, so to ascertain or validate the efficacy of this point of care testing device with that of a laboratory method, again we need to keep in mind that it is mainly for the screening purpose, and second, management of cases in resource poor settings, and three, where there is a lack of access to the EQUAS or the proficiency testing. So in such scenarios, we can opt for the point of care testing. However, here again, what should be done is we have to still validate it with the split sample analysis. Now, this point of care testing devices, it mainly works on the anodic symmetric voltammetry. So this is a diagrammatic representation of the procedure which I had explained earlier on. So here you can see the treating of the RBCs, the release of the lead from the RBCs, binding of the lead to the reference strip or the electrode, mercury electrode, and then here you can see the stripping of the lead when the potential is increased. So wherein there is a electrical potential which is created, which can be used for quantification of the lead. Now, what are the scenarios wherein we will have to consider the lead estimation? So this is something similar to what I mentioned in the introduction. One is, if at all, if you're looking at the occupational exposure, so for the management of the lead poisoning, so here, if we are managing a case of exposure to lead and subsequently developing the toxic symptoms, acute
Why moving like
or
this?
chronic, so here for the
Half an
clinical
hour
decision
back.
making, we'll have to go for the laboratory methods. Then for the exposure and risk assessment also, preferably it will be the laboratory methods like ICP-MS. Third, for screening and surveillance and occupational monitoring, here for screening purpose, we can use the portable devices. But again, if at all, if there is a suspicion of exposure or increased levels of more than 5 microgram per deciliter, still then we have to go for the laboratory confirmation.
Today, your friend is coming with you.
Now, what are the ethical considerations
Amisha.
of studies on lead measurement? So,
I told Amisha is coming in bus.
as discussed earlier on, there is a gap which has to be bridged with research regarding the individual susceptibility
Where you not ask?
and the exposure, and the genetic component also should be kept in the mind. So when we are performing research,
For this statistic.
especially with regard to the lead measurement, the few of the things which is a must includes: one is the written informed consent, two is the confidentiality, three, report disclosure, and when we are disclosing the report or discussing with the patient, again effective communication. And once if we are doing a study on exposure, doesn't mean that we have to stop there. If the exposure is identified, so what intervention has to be done, and what is the evaluation, management, and follow-up of these patients should be done. So these encompass the ethical consideration of any studies which is being done on the lead measurement.
Government office ರಜಾ ತಾನೆ ನಾಳೆ ನಾನು ಏನ್ ಕೇಳ್ತಾ ಇರೋದು ನಾಳೆ ರಜಾ ತಾನೆ.
To summarize and conclude, so the measurement of lead should be done considering the public health, as we evidenced from the previous presentation that lead is all pervasive. Then two, for the human biomonitoring in circumstances of occupational exposure, and three, for clinical management of lead poisoning. And for the estimation of the blood concentrations of the lead, one of the important thing what should be kept in the mind is it should be an accredited laboratory, and the samples includes two. One is the venous blood, and next is the urine. So the urine sample also is collected for estimation of blood using the laboratory methods. And when it comes to the blood sample, so the venous sample collected by phlebotomy, it should be in a royal blue top container, and the urine sample, it should be in a sterile acid washed container.
He is going for home.
If it is for the field visits or for point of care testing, so it will be a tabletop instrument like an example what I would quote is the LeadCare 2 or LeadCare Plus or LeadCare Ultra, any of this or any point of care testing instrument. These are based on the anodic symmetric voltammetry, and but caution should be kept in mind when we are using these POCT devices. They are beneficial or helpful for screening purpose. So for screening and surveillance, they are helpful. For the public health, occupational health, and clinical management of lead poisoning, or if there is a decision making which should be done, so for these we have to go for the laboratory methods.
Okay.
So with this, I conclude my presentation. Any questions can be asked or can be posted in the chat box.
Mo's next floor gaya wo bachcha kahi.
Hello, sir. Can I ask a doubt? Hello.
गाड़ी खड़ी है ना डिपार्टमेंट को.
పార్టిసిపెంట్స్ అంతా చెక్ చేయాలంటే
Yeah, in the chat box it's posted. Yeah, I acknowledge the correction. Yeah, there is a typographical error, anodic stripping, because the lead is being stripped from the mercury electrode. Thank you for that correction. Any other questions? There is a question regarding the cost of the screening device. Sir, regarding this, I think the batches, this is a Lead Care Plus or the Lead Care 2, they are the company is the Magellan. So there was a what to say call for of these instruments by the company itself because of the fact that it was giving a falsely low lead level. So again, now in the March, they again released the Lead Care 2, which is now made available. I think the cost also will again, I think we'll have to look into it. I'll definitely get back to you regarding the same because it is a instrument manufactured in the US. So the import and other things will change from time to time. So I'll definitely look into it and I shall revert back with the answer because there was a call for of all the 3 batches by the Magellan company. That is the Lead Care 2, Lead Care Plus, as well as the Lead Care Ultra. But to the best of my knowledge, I think from the March end, the Lead Care 2 is now again made available. So I'll just check with the same and I'll shall revert. Yes, sir. Yeah, definitely when we are looking at the field level, the cost also should be kept in the mind. So compared to the what to say, the laboratory methods, this will be a little bit cheaper only. But however, I can tell right now the cost per sample, what we incur for the laboratory methods is anywhere around 1,600, 1,200 to 1,600, wherein the methodology is inductively coupled plasma mass spectrometry for the urine sample or the blood sample. So that is the confirmatory diagnosis. So the cost per test of that is around 1,200 to 1,600. That is again varying from the lab to lab. But when it comes to field visit, as I gave an explanation earlier on, I will check about the whether it is now made available again and revert back. Thank you, sir. Thank you for making that point. Any other doubts? Okay, thank you, everyone. And now I call upon Dr. Munilakshmi, madam, for proposing the vote of thanks. Over to madam.
Good evening, one and all. I take this opportunity to propose vote of thanks on behalf of Department of Biochemistry, Sri Devaraja's Medical College. First and foremost, we salute our late founder president, Sri R.L. Jalappaji, who continues to be a beacon of light. We would like to thank our patrons of Sri Devaraja's Education Trust, Honorable President, Sri G.H. Nagaraja sir, Honorable Vice President, Shri R. Rajendra sir, Honorable Secretary, Shri Hanumantaraju sir, Honorable Chancellor of Shri Devarajara's Academy of Higher Education and Research, Shri Rajesh N. Jagdale sir, Honorable Vice Chancellor Dr. Pradeep Kumar sir, Registrar Dr. K.N.V. Prasad sir, Dean Faculty of Medicine Dr. Sriramulu sir, Medical Superintendent Dr. Sheila ma'am, and Vice Principal Dr. Shashidhar K.N. sir. I also extend my thanks to other officers of the Academy. I thank Dr. Sriramulu sir, Principal STMC, for his unceasing support and encouragement. I thank distinguished alumni Dr. Rakesh sir, Scientist D, ICMR National Institute of Occupational Health, and Dr. Harish R for accepting our invitation as speaker and delivering an insightful presentation. Thank you, sir. I thank all the faculty members and stakeholders of STHR for their enthusiastic participation in the event. Last but not least, I thank the non-teaching staff, photographer, and technical team members who are part of this program. Thank you, one and all.
Thank you, everyone. The feedback forms shall be shared shortly to all the registered participants, and the certificates shall be auto-generated. Thank you for your participation. Thank you, one and all. And Dr. Rakesh, thank you for obliging for and accepting our invitation for being the speaker. Thank you very much.